one of the most controversial topics, but we are getting there. So I'm going to go towards 2 or 3 guidelines, and you can see this is predominantly Western, which kind of highlights the difference between what we face in the East versus the West. So what are the current definitions of ACLF? What are the issues? What are organ failures specifically defined as in these? What are the biomarkers that have been studied that could hopefully put these things together and make, dare we say, a universal definition? And what are the implications if we do not agree? And what are the future directions? So this is a nice review written by Dr. Sareen and Dr. Kulkarni recently in Journal of Hepatology. There's a pre-ACLF, there's a PASL definition, there's the EASL definition, and then there's the NACSL definition, which we were involved in, including Dr. Kamath, who's sitting right here. And here is my judgment. Again, this is my personal thing. This is too early, this side. This is too late. The horse has already left the barn. And this is too obvious in the end. All of these things are very, very obvious. So I can tell you the first time ACLF was defined here or whenever, they're like any person who has eyes and ears will tell you that someone with 4 organ failures is going to do much worse than someone with 0 organ failures. So we have to go above what is obvious to every single person and find out a way to figure out how we can make this so that we define which patient is going to be helped. So quickly going over the PASL ACLF Research Consortium definitions, EASL, CLIF-C, and NACSL Consortium definitions. You can see there are the big differences in organ failures. So the major organ failures in the PASL criteria, predominantly hepatic. In EASL is hepatic and extrahepatic, and NACSL is almost all extrahepatic. The issues, the diagnosis can may be earlier, but sensitive but not specific. Diagnosis of ACLF or EASL CLIF is maybe too late, but there is a lot of emphasis on kidney dysfunction. And the diagnosis for NACSL, which was predominantly made to figure out in whom care is futile. So it is really much later on in the course. So this is when to withdraw therapy or when to think this person may not be a transplant candidate. So what are the issues with current definitions? There's discordance as to the underlying liver disease severity and precipitating factors. They are not prognostic, but diagnostic, because end organ failures are more likely related to death. They need to be more proactive than reactive. And this slide, unfortunately, is taken from my own D.V. Datta oration in 2014, 10 years ago. More definitions have actually come. We are not being unified. 10 years is the same thing. I've been here. It was in Mumbai that time, but I'm here today telling you the same thing. And our patients are suffering while we argue about definitions. So what are the current issues with definitions? There's ACLF in the middle. The problem is it's very easy for us to define what is the difference between acute decompensation and ACLF. We pretty much have a handle on that. We also know acute liver failure in ACLF, but what we don't know is there something unique in the liver. Is this something that is unique to critically kill patients with liver disease, or is it just something that happens because people are critically ill? So until and unless these are resolved, a biomarker will be a big problem to do this. So what are the biomarkers that have been studied? Inflammation, lactate, metabolomics, microbiome are few of the ones we can talk about. Clearly, inflammation is a big deal, very big deal. You have metabolic mediators which affect all parts of the immune system. There's hepatic microenvironment and of course gut microbes, which we'll talk about a little bit later. And that depends on what insults the patient actually had. Moreover, the systemic inflammation leads to changes in lipolysis, glucogenolysis, and proteolysis. It affects every part of the body. So there is liver failure causes inflammation, and inflammation with stressors causes all these things to not shut down simply, but actually be less effective. So ultimately, the energy available to the actual cell is much, much lower, and this is an inefficient use of energy which actually grinds the things down. What about impact of clear systemic inflammation on prognosis? In this nice study from Padua, they were able to figure out whether C-reactive protein, very simple to measure, was able to actually add to our definitions. And you can say that the ACLF risk was much higher in the high-risk group. This is more of a prediction of who will develop ACLF. And again, what else have been used? These are all these things which kind of overlap with what Dr. Maiwal has told us, and AKI development right here and ACLF development. But the question again is, IL-6 is not the easiest thing to measure. CRP is relatively easy. But there's still a huge overlap between who will get this and who will not. So the biomarker part of this is a little less resolved than we would like it to be. What about lactate? Multiple studies have done, including from ILBS, that this is actually important. In this study from North America, you can see the MELD lactate score was higher, but you can see the overlap right here. There's a huge overlap between 0 and 4 organ failures. And we do not do lactate in every single person. We do it not as a protocolized way, but in clinical practice, we tend to do it in people whom we think are sicker. So there is a huge selection bias right there. There is MELD lactate here again as a probability of in-hospital mortality, and you can see, not surprisingly, the higher your MELD lactate, the worse your mortality is going to be. And the delta lactate is actually very prognostic. Same here in this situation, the improvement in prediction with lactate was a little bit higher. But until and unless we use lactate in every single person who comes to our hospital, which is highly unlikely because it is expensive, it takes a little time to do, and unless done by the bedside, it becomes a little problematic. What about microbiota? The microbiota have been used in actually figuring out who will develop ACLF. This acute hepatic encephalopathy, clearly the microbes will predict. And microbes will also predict who lives or dies on admission, both when done at one time and those that were done at multiple times during the patient's hospitalization. Anything that is in the red here are microbes from patients who ultimately died. Anything in the blue are patients who actually lived. And you can see there's a separation in this PCA plot between the two. The important thing is the microbes need to be fixed before the patient comes into the hospital. Because if the patient is coming to the hospital, it's a little problematic. Microbiota are also not easy to measure. It's quite expensive and there's not a quick turnaround. So when you're talking about patients at this point, microbiota may not be the best biomarker around. Let's talk about metabolites. Some of the metabolites were already mentioned by Dr. Maiwal, but in this study, we were able to find out microbial products were able, including aromatic bile acids, amino acids and bile acids, were able to figure out who was actually going to develop ACLF. Because that's what we want to prevent, not just diagnose, we want to prevent ACLF. And this study done from the European consortium found similar things, but including more things related to inflammation in patients who already had developed ACLF compared to patients who did not. And this is a summation of the metabolites, the metabolomic studies that have been done across consortia. And this was an editorial that we wrote in response to a very nice Chinese paper in which brain failure, these things, anything in the green was higher, and anything in the red was lower. Death, ACLF and renal failure in patients with cirrhosis could be predicted on admission with multiple consortia. And these are the biomarkers that Moreau et al. All of this we had done the LCMS as well, but some of them did not. But what it tells you that metabolomics actually may be one of the ways which you can do it, provided we have a signature of 3 or 4 metabolites that can be done on baseline translation. Because not only could they be prognostic, they could also tell us who's going to develop ACLF in this situation. So ultimately, what is needed in a biomarker? It has to be objective, it has to be reliable, it has to be specific to ACLF and distinct from acute decompensation and from other patients without cirrhosis requiring critical care. It should be easily translatable into clinical practice and determine who is a candidate for liver transplant, because ultimately that's what we want this. Otherwise, why are we doing this? We are doing ACLF definitions because we want to give a patient a survival advantage by either upgrading them onto some list that helps them or giving them therapies that would ultimately not be given to people who do not have this condition, or worse, saying that this patient has not improved, so we should really bring things down, talk to the patients and do something related to futility. So another aspect that we have often not talked about, and the Cleared Consortium, thank you all for being part of it who are in the audience, has told us that not every place has the capability to handle patients. So if, for example, if your ACLF definition requires people to have mechanical ventilation, but the patient's family cannot afford and it's paid for a ventilation, then your definition is not applicable to those patients at all. Or if you have 3 ICU beds in your entire hospital, and this is one of the patients who you are not going to be able to translate that definition. So another realm of this definition is to actually make sure that it is applicable to all. So not being in a high income country, inability to afford therapies or intervention, and inadequate healthcare infrastructure, which is way beyond our pay grade. That's not something that we can do, but all we need to do is to make definitions that could be ideally translatable throughout the world. If you have poor pre-admission care, which means the patients are not seeing you as often in the outpatient setting, therefore they come to us when there's no choice. They are in a much larger, much worse situation. So the chances of them improving during the hospitalization are much lesser if they had come sooner. And this translates into poor post-admission care also for those who survived, which means this cycle of admission and readmissions will continue. Therefore, what we found, higher death, lower palliative care, and lower liver transplant care in sites that were not high income care, income facilities. What we're doing right now is to go individually, patient by patient, because what we ended up doing is actually taking a country as a whole. But clearly, someone in India who has a lot of money will do much, much worse, much, much better than someone in US who is uninsured. So just being in the US does not automatically give you a survival advantage. Every patient is very different. So what we want to figure out is not only the definitions are applicable to one part of the world, but they have to be applicable to everyone. And this is the definitions, and you can see death were predicted by lack of resources, and especially in low and middle income countries. So what are the challenges in justifying liver transplant priority for ACLF, which is probably what we are going for here, right? How can we upgrade someone on the list, especially in those who are in deceased living donor countries? It actually, I would argue, it actually becomes even harder to justify in people who are living donors, because if your outcome for living donors is not as good because you waited too long to define ACLF, then you're not only stuck with a patient who has a poor outcome, you're also stuck with a donor who may or may not have a large amount of complications from the surgery itself. So this is a nice review written by Dr. Reddy's group. ACLF is a controversial entity, which is why we are having this definition. Understanding of ACLF is not uniform. The different classifications are a problem. Many patients with ACLF do not have liver organ failure, therefore threatening the construct validity of this as well. The challenge is scoring is complex and it changes. If you go around and come back during the afternoon and draw that blood again, the patient may have moved from one to the other or may have gotten confused because of an infection that they developed in the hospital. They are not static. Components may be manipulated, of course, including pressors and intubation. Alcohol hepatitis could receive further hepatitis. In fact, the dial is moving so much in the United States towards giving patients with alcohol hepatitis that our patients with decompensated cirrhosis are really suffering. So we have to do a course correction very quickly because patients with alcohol-related hepatitis have a very high bilirubin. They tend to have AKI, things that would advantage them in a high MELD situation. And again, multiple organ failures and ICU transplant have poorer outcomes. So there have to be clear guardrails assigned. So in summary, multiple ACLF definitions ranging from the too early, the too late, to the too obvious. Most definitions do not consider chronic disease. They do not consider transplant eligibility and availability and changing precipitants around the world. Biomarkers have shown promise, but currently not to the point of reduction to practice. The closest one we think is maybe the metabolomics, which may be sensitive and potentially specific in predicting and diagnosing. A meeting of the minds has started, thankfully, from the APASL-Kyoto definitions, from the APASL-Kyoto meeting. We are going to have another meeting at ASLD, and hopefully it will continue this during EASL so that we can actually bit by bit try to solve these problems to come up with the least unacceptable definition. It will never be acceptable by all. So a meeting in mind is necessary because if we do not agree on a definition, our patients will continue to suffer and they deserve better. Thank you.